Good morning. I'm Donna Gairns, the National Lymphoma Nurse Manager with Lymphoma Australia, and we're at ASH 2019 in Orlando, Florida. And this morning I'm joined by Professor Simon Rule from Nantes in France, and he's going to be updating us a little bit about some of the Mantle Cell Lymphoma trials he's been doing. Good morning.
Good morning. Nice to see you.
Great to see you as well. I understand you've got an abstract that has been presented at this conference for upfront mantle cell lymphoma.
Yeah, we presented the abstract on Saturday morning. So it's first release of a trial called Oasis. It's a trial we're running with our colleagues in UK with Simon Rule. And so the two of us built a quite innovative trial where we use a combo, which three drugs, so it's a triplet. Obintuzumab, which is a CD20 antibody, Venetoclax, which targets the mechanism of death of the cells, BCL2, and Ibrutinib, which is a well-known BTK inhibitor. Also, these are the last two as two oral drugs. So we give this triplet to patients newly diagnosed and treatment naive. And it's a small cohort, it's 15 patients, and the results are very encouraging. So we're looking forward to have more patients in the coming years.
Oh, excellent. And what was the sort of overall response you've got from those 15 patients?
Yeah, so 15 patients newly diagnosed, and 14 out of 15 were in complete remission after 6 months of treatment. And these include complete remission at the molecular level. So it's a very deep and profound response. And some patients are already treated for 15 cycles. So that's a very good news. And the part that we really look at is the prognostic features and markers of these patients. And there are some genetics markers like we call P53 mutation, 70p deletions. These are bad markers, and we have quite a lot of patients with these features, and they all reach complete remissions too. So that's a very good news, something we did not really expect, but it's very high response rate. So we're very happy with that, and it shows that these kind of, which they non-chemotherapy or targeted therapy approach, whatever the term you prefer, seems to be very active frontline, and that's a very good thing.
Oh, that's fantastic news for the mantle cell lymphoma patients. And what sort of a side effect or toxicity profile does that treatment have for these patients?
Yeah, you're right. It's a very good question because when you go frontline, you want to have a treatment, that's a relapse, of course, but frontline, you don't want to jeopardize more than needed the quality of life of the patients. So what we observe is when you give this triplet to these treatment-naive patients, it's extremely well tolerated. Probably much more than that time relapsed refractory, because we also did a cohort of relapsed refractory patients that didn't present it here today. But the side effect or the toxicity of the triplet at relapse was higher than frontline. So this really reinforced the fact that it's probably better to give this drug frontline, because the patients have not been exposed to chemotherapy before, so they don't have chemotherapy side effects. The bone marrow is still very well, so thrombocytopenia, neutropenia are less frequent than if you come after chemotherapy. So the idea in the back of the mind with this kind of treatment is to switch the paradigm, not chemo first and chemo-free second, but chemo-free first and chemotherapy second if needed. That's the point. That is where we want to go.
Fair enough. Have you given this sort of protocol in the refractory relapse setting as well?
Yes, we treated relapsed refractory patients too. 24 patients were treated, was presented last year at ASH too. Though we have a more longer follow-up, so we have a very nice response rate too. About around 65% of the patients reach response. There are a little bit more side effects, but something which is perfectly well tolerated. But if you get a good combo, a good triplet, what you want to do is to give it as early as possible and not wait a relapse. And what we see is better response frontline, better tolerability profile frontline.
Oh, it sounds fantastic. And just for a bit of general sort of overview where we're at with standard treatment off trial for the mantle cell upfront patients, what sort of treatments are still the best for those patients?
Yeah, I think you're right. It's important to mention that we're talking about clinical trials. So this is not standard practice at all to give this triplet. I think no one should do it outside of the clinical trial. So the standard of care for mantle cell, well, it depends if you're fit enough to go to the transplant. So those patients who are transplant eligible, autologous stem cell transplant, those usually below 65 or 70 years old, They receive a first line of chemotherapy, which has to contain a drug that is called cytarabine. So high dose cytarabine followed by a consolidation, and in the consolidation, this is where we put where we use the autologous stem cell transplant. And there is another recommendation after the transplant is to use rituximab, CD20 antibody maintenance for 3 years. I say that, but I know that in some countries you can get access to the maintenance because of reimbursement and of stuff like that. It's always different one country for another, and I know that how it is in Australia. But I think it's important to say, at least if you look at the ISMO, the European recommendation, it's clearly stated that rituximab maintenance should be given after autologous stem cell transplant. So this is for the young one. For the elderly or frail patients, of course, the autologous stem cell transplantation is not part of the game. So it's a standard chemotherapy. It might be bendamustine, rituximab, or R-CHOP. So this depends on your practice or countries. In France, we are more R-CHOP people. In Germany, BR. I guess it's also BR, UPR, right? So it's the way it is because they've never been really compared front to front. And bendamustine, for example, is not reimbursed frontline in France, so this is the same issue, So R-CHOP, BR. After R-CHOP, it's also recommended to use a rituximab maintenance, right? So this is clearly, it has been clearly demonstrated. After BR, there are still questions pending whether or not a patient should receive a rituximab maintenance. It's still a gray zone.
Fair enough. And in the refractory relapsed setting?
Now, this is where the landscape has changed so fast. So there's a new class of molecule, which is not that new now, which is called a BTK inhibitor. It's an oral drug, targeted therapy, that really target a key system in the tumor cells and block this system so the cells cannot proliferate and they don't stay in their natural niche, which is the lymph nodes. And when they are not in their niche, they don't feel well at all. This is what we're looking for. So this BTK inhibitor, and Ibrutinib were the first to be approved, is the major drug used in relapse. But I wanted to highlight that for some patients, having a second line of chemotherapy is sometimes a good thing. If you enjoy very long response rate, very long duration of response, and unfortunately you relapse years after frontline of treatment, maybe it's a good thing to have, again, a short chemotherapy, to be again in CR, and enjoy a long new CR. So nothing is really standardized, but Ibrutinib it's an important drug. And there are other comings, like the triplet, the combo.
It's fantastic to know that there's more things on the way anyway. It's fantastic results. Thank you. Well, thank you so much for your insight today, and I hope you enjoy the rest of your conference.
Thank you. You too. Enjoy.
Thank you.